Hello, welcome everybody to GAP MASLD and MASH Community Network. My name is Christina Hanson, and I'm a nurse practitioner working at South Denver GI in Colorado. I've been working at South Denver GI for a little over 18 years and general GI and liver. And today I'm going to be talking about pharmacotherapy for MASLD and MASH, a basic overview. So one of the things I want to start with in my discussion are what are the primary targets or histological endpoints for pharmacotherapies that are currently approved or in late stage development for MASH. And when we look at primary histologic endpoints for therapies targeting MASH or MASH resolution, really are looking at the fibrosis improvement and the resolution of steatosis or MASH. So when we're targeting MASH resolution without worsening of fibrosis and or fibrosis improvement by at least one stage without worsening of MASH really are the endpoints that are widely used in clinical trials and are accepted by our regulatory agencies like the FDA here in the United States and the EMA, which is the European Medicines Agency, so what usually oversees clinical trials in Europe. So let's break this down a little bit further. When we talk about MASH resolution, this is defined as the reduction or elimination of steatosis, that fat accumulation in the liver, lobular inflammation, and ballooning degeneration, so that swelling of the liver cells, to a score of 0 or 1 for inflammation and 0 for ballooning, with no worsening of fibrosis. And then when we look at that other efficacy endpoint of fibrosis improvement, this refers to a reduction in the severity of fibrosis in the liver and is typically measured by a decrease of at least 1 stage or greater in the fibrosis staging system. And this is often assessed using the NASH Clinical Research Network, or the CRN criteria, which considers 4 key features: biopsy looking at macrovesicular steatosis, lobular inflammation, hepatocellular ballooning, and fibrosis. And again, that's what we typically see in current late-stage development clinical studies, as well as what the FDA required for our approved therapy, which is Resmetirom. So let's actually move into talking about a little bit more about Resmetirom, talking about the mechanism of action and really the key efficacy data from the phase 3 trials that led to approval. I'd also like to touch on a little bit about the safety profile of Resmetirom as well. So this medication was the first FDA-approved therapy for MASH, and it works specifically by activating thyroid hormone receptor beta, THR-β, in the liver, which regulates lipid metabolism and reduces inflammation. In phase 3 trials, it demonstrated efficacy in resolving fatty liver, or NASH at the time, now we know it as MASH, with no worsening of fibrosis. The most common side effects that were seen with Resmetirom in the trials were diarrhea and nausea, which were generally mild and transient. We'll talk about that a little bit greater detail later on. But let's talk a little bit more about this mechanism of action. So Resmetirom, again, is a liver-directed selective thyroid hormone receptor beta agonist. It stimulates THR-β signaling in the liver cells, and through this promotes lipid metabolism and reduces fat accumulation. By selectively activating THR-β, Resmetirom avoids systemic adverse effects that are associated with thyroid hormone excess that's mediated mainly by thyroid hormone receptor alpha. So it has no concerns around toxicity, systemic toxicity. It also improves mitochondrial function in hepatic cells by inducing mitophagy and lipophagy and fatty acid beta oxidation. So let's shift and talk a little bit further about the efficacy data in the phase 3 trials. So looking at the MAESTRO-NASH trial, it had a dual primary efficacy endpoint at week 52 of treatment. And remember, there were 3 arms in this study. There was an 80 milligram dose, a 100 milligram dose of Resmetirom versus placebo. And these dual primary efficacy endpoints included resolution of steatohepatitis. So again, we talked about that score of 0 to 1 for inflammation, 0 for ballooning, and any value for steatosis with no worsening of liver fibrosis. So it actually had to resolve fat steatohepatitis without worsening fibrosis. And the second endpoint in the dual primary endpoints was fibrosis improvement by at least 1 stage or greater without worsening of steatohepatitis. And liver fibrosis, again, was evaluated on the CRN, the NASH Clinical Research Network, fibrosis, with a score as 0 to 4. Rezdiffra actually achieved statistically significant results for both NASH resolution and fibrosis improvement at week 52. And in the MAESTRO-NASH trials, about 25.9%, so nearly 26% of patients on the 80 milligram group, and 29.9%, so nearly 30% of patients in the 100 milligram group, achieved NASH resolution with no worsening fibrosis, compared to 9.7% in placebo. And then when we talk about the second endpoint of fibrosis improvement, resmetirom also showed significant improvement in liver fibrosis by at least one stage compared to placebo. And again, improvement in liver fibrosis with no worsening of steatohepatitis. On a side note, there was actually no differences in response to Rezdiffra based on age, gender, if a patient had type 2 diabetes or not, or their fibrosis stage 2 or 3. And in a subgroup analysis, actually revealed similar response rates in patients with and without possible MASLD, which is metabolic associated liver disease, with higher amount of alcohol intake, indicating consistent efficacy across different patient populations. So let's talk about a little bit deeper dive into our understanding about which patient is the most appropriate candidate for initiating MASH pharmacotherapy. And remember, at this point, resmetirom is the only FDA-approved pharmacotherapy for MASH. And so when we look at use of resmetirom, the most appropriate candidate specifically for resmetirom is those with MASH who have stage 2 or stage 3, so F2 or F3, by either non-invasive testing or liver biopsy. And these are patients that are considered to have at-risk MASH. Patients with cirrhosis stage 4 fibrosis or those with early fibrosis stages 0 to 1 are generally not recommended for resmetirom treatment at this time. Although there is an ongoing trial looking at resmetirom in MASH cirrhosis, compensated cirrhosis, so certainly this may be a possibility in the near future. And while it's important to focus on treating our patients with MASH with fibrosis and fibrosis stage, obviously progression of fibrosis is one of the most concerning clinical predictors of liver-related mortality and morbidity. We want to make sure we're continuing to assess these patients for their other cardiometabolic risk factors and making sure these are well controlled. So we want to control the diabetes, the dyslipidemia, obesity, which are all very common in our MASLD and MASH patients. So another question or point I want to make is when we are initiating resmetirom and pharmacotherapy for MASH, how do we as advanced practice providers or clinicians want to monitor our patients, considering both treatment efficacy as well as monitoring for any potential adverse effects? And so I want to recommend that you reference the AASLD's updated practice guidelines around use of resmetirom, which was updated in October of 2024, on how to monitor patients after initiation of resmetirom for both safety and efficacy. And so certainly I want to encourage you to take a look at that. They have a practice guidance around the safety and efficacy, as well as the appropriate patient to initiate and when to consider stopping resmetirom versus continuing. And we'll get into talking about that. But let's first talk about safety monitoring in our patients with initiation of resmetirom. So general side effect monitoring is important. So I talked about how in the studies, the most common adverse events were that of diarrhea and nausea. And typical the onset was less than 12 weeks in the studies after initiating therapy and often lasted less than 4 weeks. There were actually no cases of severe diarrhea. By having the conversation around these potential side effects with our patients, monitoring their symptoms, anytime I'm initiating a therapy, I want to hear from that patient within a couple weeks. It may not be realistic to get them back in the clinic, but at least have them give me a call, let me know how you're tolerating. And then as far as safety labs and blood work monitoring throughout, it's important to point out that there was one case in over 2,000 patients studied in the MAESTRO-NASH trials that had a case of severe hepatotoxicity. And this was a patient receiving resmetirom. Biopsy actually showed interface hepatitis consistent with autoimmune hepatitis versus drug-induced autoimmune-like hepatitis. In retrospect, this patient actually met the criteria for PBC and had a strongly positive antimitochondrial antibody and antinuclear antibodies at baseline. Nonetheless, this speaks to the importance of ruling out all other potential coexisting liver conditions during that initial evaluation of our patients. So when they're first coming into our practice, we're evaluating them for fatty liver, we're staging their disease. We want to make sure we're ruling out any other potential underlying liver conditions, including autoimmune. And then regular liver function panel testing during resmetirom therapy is recommended to screen for hepatotoxicity. So again, before a treatment initiation. And then the AASLD recommends repeating a liver panel at 3 months, 6 months, and 12 months. So right around that year mark. Another recommendation at baseline is checking for thyroid function. So hypothyroidism really is not uncommon in patients with hepatic steatosis to begin with. Its relationship with development of steatohepatitis has been less consistent and confounded, obviously, by other cardiovascular risk factors. But persons with active hyperthyroidism or untreated hypothyroidism were actually excluded from the MAESTRO-NASH trial. In the trial, mean plasma-free T4 concentrations did decrease, although rarely led to any abnormal levels. TSH and T3 also had changes slightly, but consistently remained within the normal range. And actually, development of any hypothyroidism requiring levothyroxine replacement occurred in less than 2% of patients receiving Resmetirom. So the FDA integrated review of Resmetirom concluded that thyroid axis function was maintained during treatment and recommended no thyroid-specific management. However, any abnormal thyroid function, hyperthyroidism or hypothyroidism, obviously should be addressed before initiating Resmetirom therapy, which necessitates us to check thyroid function at least at baseline with at least a TSH level. And in accordance with FDA guidance, persons without any thyroid function abnormalities at baseline don't require any systematic monitoring of their thyroid function while receiving Resmetirom. But those with known thyroid disease, standard clinical monitoring, TSH, free T4 at 3-6 month intervals should be followed at the discretion of the treating clinician. So naturally, you're going to follow thyroid function testing in a patient with thyroid disease or on therapy. And then dyslipidemia also can be very, very common in our patients with MASH, and it remains an essential part of management is managing dyslipidemia. And among persons in whom a statin dose is reduced, as is recommended at the initiation of Resmetirom therapy, we really want to make sure that we're monitoring their lipid profile throughout treatment and adjusting statin therapy accordingly as needed. So remember, when we initiate Resmetirom, one of the recommendations on the product indication is limiting the daily use of rosuvastatin and simvastatin to a dose of 20 milligrams and limiting pravastatin and atorvastatin dosage to 40 milligram, because the concomitant use of these two medications can actually increase the exposure of statin and potentially the side effect. So again, when we're looking at lipid monitoring, it's recommended to check that at before treatment initiation, and you can consider repeating at 6 months or 12 months according to AASLD guidelines. And then, of course, fibrosis assessment. Non-invasive testing. Every patient with MASLD should have a fibrosis assessment at baseline and updated periodically through treatment. Obviously, we need it at baseline to determine if they meet criteria for Resmetirom therapy. So remember, this is indicated for stage 2 and 3 fibrosis patients. So we want to make sure that we're getting this non-invasive test so that we know it's the appropriate patient for a Resmetirom. So getting it at baseline and then assessing later. And I would say, practices are going to be different as far as what clinicians want to do with non-invasive testing. But typically the recommendation is to at baseline and then repeat that non-invasive test at 12 months to assess response. There really, in our practice, is not a lot of utility in repeating it more frequently because it's not going to change my practice at a 6-month mark, for instance. So we are typically checking it at 12 months, which is recommended by the AASLD. And then looking at AASLD practice guidance for assessment of treatment response in those receiving Resmetirom. They also have recommendations around this. And they break it down kind of like a stoplight, red, green, and yellow. So for those at 12 months after Resmetirom treatment initiation, if they actually have worsening of their non-invasive tests and they have a consistently persistent elevated ALT or it's increasing, this is a patient that we are going to assume is not responding. So worsening of their non-invasive tests, their fibrosis, increasing ALT at the 12-month mark. This is where we're saying, I think this patient's not having response. We're going to stop Resmetirom or we're going to pivot. And remember, these patients are stage 2 or 3 at this point. So continuing to treat with Resmetirom when they are showing no response, no, we want to go ahead and move on. But if we have a patient who maybe they have a minor reduction in their liver stiffness values, their kilopascal, and the studies in the MAESTRO-NASH trial, when there was a reduction of 30% or greater by MRI-PDFF after 1 year, really did seem to show a correlation with histologic response. So if they had a greater 30% or greater reduction, it appears that they were showing histologic response as well. So the ASLD guidelines recommend that if they have a reduction VCTE of less than 25% or by MR elastography less than 20% from baseline, no significant improvement in the ALT, but by MRI-PDFF, they have less than 30% reduction. So there's minor reductions. This benefit is uncertain, but again, remembering that they're stage 2 or 3, this is going to be up to the clinician. If they're not having advancement in their fibrosis, maybe they're not meeting those criteria of greater than 30% reduction, but they've had some minor improvements. This is someone that you might want to continue on or at least reevaluate. What we do know from year 2 and 3 in the MAESTRO-NASH trial is that the data has shown actually that there seems to be greater response as time goes on. So knowing that data is showing greater improvements beyond that 52-week mark, which is the accelerated approval response that we're basing Resmetirom approval on right now. Again, if this is something where we probably want to continue this patient on Resmetirom for longer and continue to reevaluate. But again, that's going to be clinician to clinician and patient to patient. But then the green of the stoplight, again, improvements in liver stiffness by VCT or elastography, that's at least 25% or greater. So that 30% mark that we saw in the study, or by MR elastography, greater than 20% from baseline. And these patients have normalization or significant improvement in their ALT. And the sweet spot in the trials seemed to be a reduction of at least 17 points or greater in their ALT, seem to correlate with histologic benefit. These are the patients that are proving to have beneficial response, and we want to continue them on Resmetirom. So again, I encourage you to look at the ASLD practice guidelines on safety and efficacy recommendations around use of Resmetirom. So with that, I'm concluding this podcast. Thank you for listening in, and certainly thank you to Madrigal for supporting this series.